I'm hitting the button now, Alfonso. It'll take probably, it's not quite ready to go yet. It's streaming to get it set up. You were good to go, Alfonso.
Well, good afternoon. This is Alfonso Alexander, and I am excited to welcome you again to the Man Up Men's Health Initiative. Today, we've got an outstanding discussion that I think you guys will learn from and enjoy. This discussion today will be moderated by Kenyatta Lovett. Dr. Lovett, welcome. Good to see you. He will ask questions and lead a discussion with Dr. Derek Griffith and Dr. Isaac Thompson. These guys are phenomenal in what they do and are helping lead the country in terms of research and other information that they are gathering regarding COVID-19 and the global pandemic that we're experiencing right now. So I'm going to sign off and turn it over to Dr. Lovett, who will lead the discussion, and we'll see you back later with additional questions that I will be taking from you guys that will post questions on Facebook. So if you would, just slap your questions over there in the chat area, and we will pull those questions and come back and ask at the end of this dynamic discussion. So Dr. Lovett, I'll turn it over to you. Have a great one.
Thank you, Alfonso. I'm looking forward to talking with you later on in the conversation. All right, good afternoon, everyone. And this is another session from Man Up Men's Health Initiative. And this is a great discussion, title being COVID-19 vaccine, a real discussion. And this is going to be a dialogue about decisions and facts. This is also a way in which we can connect with global expertise that is actually right here in our own backyard in Tennessee and in Nashville. Or as the credit card slogan says, internationally known, locally accepted. We have two experts that we look forward to talking to on this conversation. But more importantly, this is an engagement opportunity for everyone that's in the audience to talk about a critical national conversation about the COVID-19 virus, the vaccine, that looks very promising and how that impacts your daily life. Just some backdrop on some of the latest news, and this is over the past 24 hours of how COVID-19 has impacted this immediate area, Davidson County and abroad. Within Davidson County, it was just announced more than 4,500 new cases were reported, including 55 new deaths. Also, it was reported, and I'm not sure if this is accurate, it's kind of scary for a data point, but 25% of the cases throughout this year have been recorded in November. I'm not sure what that means, but Johns Hopkins University reported that in an article. And then WSMV, in a recent story that they covered, which had one of our participants or panelists, Dr. Thompson, noted that 1 million children currently are stricken with COVID-19 across the nation, which is a very scary reality. So without no further ado, I want to allow time for each of the panelists to offer their introduction. And I'm going to, if you're okay, I'll kind of state your name and title, but if you could just introduce yourself and who you are and your role in the COVID-19 recovery effort. And then I'll pepper you with a quick question, and then I'll go to the next panelist and allow them to introduce themselves and then also offer questions. So I'll start with Dr. Derek Griffith. Dr. Derek Griffith is a professor of medicine, health, and society, and the founder of and director of the Center for Research on Men's Health at Vanderbilt University. And he will be our expert, really covering the decision factors, the disparity factors that impact how we could potentially recover from COVID-19. Dr. Griffith, if you don't mind, just to introduce yourself, and I know I kind of gave it away on your title, but you can explain it in a lot more detail than I can. And welcome to Man Up Health's discussion today.
Well, let me first say thank you for the opportunity to speak with you and for joining you, to be able to join you today. And it's a very important discussion. As you said, my work is really more in the social and behavioral sides of health. I do a lot of work on the health of African-American men and on racial and ethnic health disparities, and just how we try to understand factors that influence our communities differently, so forth. A lot of the work that we're doing right now, we have a project looking at the notion of trust in healthcare and in healthcare delivery. And so we utilize those principles a lot to think about how those factors are going to influence or are currently influencing people's response to the COVID vaccine, to COVID, to wearing masks and those kinds of issues. So that's a lot of what I do, is really how to think about social and cultural factors and how they affect health.
Great. And the question I have for you, and this is going to set the tone for the overall conversation today. And I believe it would be useful for the audience to offer, if you could offer a quick snapshot on your approach to, and I'm using your terms, which I really like, embracing diversity as a strength as it pertains to this current health challenge brought on by COVID-19, but also overall, how can diversity as a strength improve health policy, also health research and medicine research out there across the nation, and especially as this current situation is plaguing us right now?
Yeah, I mean, I think there's the old saying, with every sort of crisis, there's an opportunity. And so I think this is an opportunity for us to really reimagine the public health and medical sort of infrastructure for how we need to do things like respond to emergencies, respond to, different threats to our health and well-being. One of the things that COVID has shown us is really the gaps and the problems that we have and the disconnects between our healthcare system and our public health system. The public health system is basically everything outside of the health, outside of what happens within the doctor's office to help improve your health and well-being. Public health is really sort of the environment around it, and how do you deal with things like pollution? How do you deal with the airborne exposures? Those kinds of things, the policies that are guiding what restaurants or what kinds of businesses are open or closed and those kind of things, that all really has to do with public health. And so what COVID has really done is really illuminated the gaps that we see, or the disconnect sometimes that we see between our particular systems in public health and in healthcare. And so I think this is a unique opportunity to think more broadly, and it's kind of forced us to really adapt to this pandemic in a way that is going to require us to really think more creatively about the solutions that we come up with, because the typical things that we've been doing have not really been working as it relates to particularly the second wave that we're seeing, where you are seeing this very dramatic sort of rise. It's not just sort of been an incremental rise. The numbers that you were pointing to that are very recent are showing a much more sort of dramatic increase in the rates of COVID, and a surprising rate of mortality from COVID that we weren't seeing before. We were kind of seeing this sort of the mortality rates kind of flattening out, and the COVID rates kind of flattening out too, but we're now starting to see that actually increase.
That is a scary, scary reality, and thank you. And looking forward to this dialogue that we will all learn a lot from. And next we have as a panelist, Dr. Isaac Thompson, Assistant Professor of Pediatric Infectious Disease and also at the Vanderbilt Vaccine Research Program. And Dr. Thompson, if you don't mind, just introduce yourself and welcome to Man Up Health, the Man Up Health Initiative discussion today.
Yeah, thanks for having me. Good afternoon. And yeah, I'm Isaac Thompson. I'm with infectious diseases at Vanderbilt. And I think as we think about our response to this pandemic, most of us in infectious diseases have to some degree dropped everything. Whatever we thought we were going to be working on this year completely changed, as it did for many of us, no matter what our field is. But for those of us in infectious disease, it was, we need to band together and figure out how to address this. And my role in it has ranged from helping early on to assess possible treatments. There's this antiviral, a drug called remdesivir, that was developed in part in the lab of my division director, Mark Dennison, here at Vanderbilt. We helped in the study to see the effectiveness of that. Some trials looking at transfusions of plasma, so blood from someone that's recovered from COVID being drawn, and then the immune component of that being given to a patient with COVID. So we're evaluating that. And then most recently, and probably most importantly for getting us all out of this thing, we've been involved, as a lot of the country has, in the vaccine trials to evaluate potential safe and effective vaccines against COVID. This is a large national and even global effort. It's not, it takes a village, it takes a country and a world to get this thing under control. And so I think we'll have a chance to talk more about that in detail today, but that's really consumed my and many of my colleagues' recent time in this area.
And my question for you, and just know, this isn't formal research, this is just me asking my 14-year-old a few minutes ago, would she be open to taking the vaccine? And obviously everyone appears to be, from her answers especially, an expert on how the vaccine may or may not be safe and what actually research and what activities take place to create a vaccine. For the audience, if you could just give a 101 on how vaccine research and distribution takes place from the point of activation all the way to the point of distributing that to the general public.
Yeah, I think there's a couple of core points I think it's helpful for everybody to understand and be aware of. Is when there's a potential vaccine, we call it a vaccine candidate, there's really two things that have to be assessed, and they're equally important. It is the vaccine effective, and is it safe? And both of those things matter equally. If it's extremely effective, it doesn't matter if it's dangerous, if it's not safe. Vice versa, if it's safe, it doesn't matter if it's not effective. So we have to assess both of those things. It gets a little challenging because those are not just yes, no. Safety is not just safe or not. There's degrees of safety. Effectiveness is not yes, no. There's degrees of effectiveness. So we have to assess that. And really that's done typically in about a 3-step path. The very first step, we call it a phase 1 trial, and that is purely focused on safety. It's just some otherwise healthy adults, usually about 50 folks, and they just get the vaccine, and you kind of stand back a little bit, just say, how's it going? Very little effectiveness evaluation. It's just, is this okay to put in people? And then when it's shown that it is, you go a little bit larger, a phase 2 study. Now you're looking at 500 or 600 people. And this typically is a range of doses, and you're starting to ask some questions about the immune response of the vaccine, and also still with a close eye on safety, because you've got a larger group of people. And you're really trying to find what's the sweet spot, because typically with vaccines, as you increase the dose, you get a better immune response, but you also get more side effects. And so we want to find that perfect balance where the dose is just right. It's good enough to be a good protective vaccine, but you're not going to get a lot of side effects. And so that's what the phase 2s usually tell us. And so then after that, we say, all right, this is safe in a good number of people. We've got a good idea of the dose. And then you go big. And that's what the phase 3 study is. And this is what, if you've seen the headlines the last couple of weeks about 2 of these COVID vaccines, one made by Pfizer and the other a company called Moderna, their phase 3 trials have wrapped up. They're being analyzed. They're still going, but the early data, and these are big. These are 30,000 people in each study, and each of these half get the vaccine, half get a placebo, just a saltwater injection in the arm. And so this is wide, and this is just what are your chances of contracting COVID while you're in the trial, and then you analyze that based on who got the vaccine and who didn't. And when we hear this news that came out in the last couple of weeks that these vaccines are 90 to 95% effective, that basically means that you take all the COVID cases in the study, and 95% or so of the COVID cases, they got the placebo, and only about 5% got the vaccine. And that's really strong evidence the vaccine's really doing something. We're still looking at safety. Now you've got a big net of a lot of people, and so there's still that close eye on safety. We can talk more about this because it's a really important part of this. I think one of the concerns we hear from folks is this has happened really fast. Is this safe? So we can get into the details if folks want to hear about that, but we'll say that what we've seen for large scale across both of these large vaccine trials, really encouraging, they work, and they seem to be really safe. So that's kind of the sequence, that sort of 1, 2, 3 stepwise phase. And then it is, all right, this seems to work, it's safe. How do we get it to as many people as quickly as we can?
Great. And we'll talk a little bit more about the distribution part of it later on. And thank you. That was a good, clear explanation. There were some things I think I've missed in the process as well. A question for you, Dr. Griffith, and this relates to, when we talk about health equity, we also have to talk about access, the access component as well for healthcare and the disparities there. And you've been an expert in this field for quite some time. Can you walk us through the dynamics of health disparities that disproportionately affect communities of color? And if you don't mind, when you answer that, also there's a couple follow-up questions, and one being, where are these disparities visible, where we can clearly see them in our society, but also where are they invisible, where we wouldn't know, but it's actually impacting how we function as a society?
Yeah, great question. I mean, so let me just start with some very basics. So if you think about health, you have to sort of define it very broadly. And a lot of times, when we get to things like a pandemic, we're thinking of health in terms of disease and illness and so forth. But if you talk to people when they talk about health, they're usually thinking about, how do I generally feel? Do I feel okay? Can I do what's important to me? Can I go to work? Can I, do the things can I function on my own? And so I think we have to sort of think about sort of these different definitions as it relates to health and well-being is sort of the broader concept. So that's the first part. When it comes to health equity, one of the things that we see is basically it's important to sort of, connect the dots of what are the social, so when you think about what actually determines health and well-being, healthcare and access to healthcare is certainly a critical part, but it's a necessary but insufficient part of actually, people being healthy. So health behavior, what are you doing to yourself and to your body, outside of the healthcare system? So what are you eating? How much are you exercising? How much are you, how do you manage your stress? How much are you, doing things that are good for you? And how much are you sort of exposed to things that are bad for you? And then you have the social and economic, we call them social determinants of health. And so without the fancy term, the social determinants means what are the social things that determine health. And in our case, social here means everything from money or your access to money, how much money you have, how much money you owe, how much stress that the money that you have or owe sort of gives you, the environment that you live in, the neighborhood that you live in, media exposure. So how much are you exposed to things in the media that are stressful to you or that are anxiety provoking to you or that are reaffirming to you? And so when you look at these things kind of very broadly, you can also get into racism and other kinds of factors that really broadly affect, just our responses and things as it relates to stress. So when you look at those kinds of things and going back to sort of the more narrow definition of health being looking at things sort of through things like life expectancy and those kind of factors, we know that there are significant differences by race and by gender in terms of how long people typically live and their sort of quality of life, as well as, a number of other factors in terms of the rate of sort of particularly like chronic diseases and so forth. And when you think about these in relation to COVID, one of the things that you've heard a lot about over the last few months has been the rates of underlying conditions and how those are affecting people's response, who's affected by COVID, and that one of the higher risk factors is for people who have underlying conditions. And usually what that translated to were things like chronic health, conditions like heart disease, cancer, those kinds of things that were sort of underlying health conditions that just make your body sort of more susceptible to disease, illness, and to risk factors sort of outside of, just the normal things that you'd be exposed to. And so if we think about those we know, again, there are significant differences by race and by gender. When you look at those in particular and how they connect to one another, we know that African-American men, for example, tend to have a particularly poor health profile, meaning that if you compare them to Black women, compare them to white men, compare them to white women, compare them to other groups of men and women, basically Black men tend to do particularly poorly when you look at it sort of overall, and particularly in the context of chronic disease. So, and we can't explain it all through healthcare. We can't explain it all through health behavior. We don't have a good sort of simple, magic bullet kind of explanation for that. But we do know sort of at each of these levels that there are a lot of health behaviors that African-American men do that don't put them in the best position as it relates to health. We do have lower access to and utilization of healthcare. We experience more and more a different form of racism. It's a gender sort of racism that tends to be connected to fear and a lot of other sort of issues. There's the historical context of things like Tuskegee, which we'll get into a bit later, and how that sort of shapes this conversation. But it's a much more complex sort of picture of what actually influences health. So there's a historical component, there's a non-health related component that influences health. And then there's the things that happen when you go to the doctor that is also really critical to factor into that picture.
Thank you. And Dr. Thompson, and this is in response to Dr. Griffin's response also, but first part of the question would be, how has this effort to develop a vaccine for COVID-19 differed from previous vaccine efforts, but related more to Dr. Griffin's point, in how we've approached the vaccine for COVID-19, have there been any determinants or have you seen any challenges in the ability to understand the response to this vaccine to different communities based on that there are maybe some disparities in who participates in studies and who doesn't participate in a particular study?
Yeah, absolutely. It's a hugely important aspect of this, and I think it's definitely worth commenting on. There are, you know, if I standing back from the whole process of this COVID vaccine development pipeline, there are two major and very important ways this differs from really every previous vaccine that's ever been developed. The speed at which this took place, and the emphasis on diversity of the participants in the trials and the focus on the underrepresented minorities that were in the trials. And so maybe we can unpack each of those in order. So the speed of it, I think, is important to get to, because as I mentioned, I hear a lot of concerns, you know, my friends, family, they say, and seems like great news about this vaccine, but it seems like it happened really fast. Should we be nervous about that? Or would you cut any corners? Why was this so much faster than every other vaccine that's ever been developed? And, you know, my first comment is typically, you know, it's almost like you can't win. Everybody wants something as fast as we can, but then when it happens, they're like, that seems too fast, you know, and it's like, so I think it's really important to emphasize, and I can't say this clearly enough, that no safety measures, monitoring, et cetera, no corners were cut with any of that. What happened that's very different than every other vaccine that's ever been developed. So as I was talking earlier about that sequence, sort of the phase 1 and phase 2 and phase 3 and kind of the typical pipeline. Normally, it's just a very slow process. There's a long period of time where a protocol is written for a phase 1 and people send their edits around and have conference calls, and it's months are going on, and then the study goes on, and then it gets analyzed and somebody writes a paper and more stuff's going around, and it's just all, you know, it's a couple of years. And then the second one starts because nobody's in a hurry. It's just sort of everybody's doing their job. Well, this was very different. As I mentioned, most experts in the field dropped whatever they thought they were going to be working on. You had an unprecedented number of people working on this, an unprecedented amount of resources from the government, from other funders, et cetera. Essentially a limitless amount of resources, because it was identified that a vaccine is the path out of this pandemic. And what happened was, what never happened before, as soon as those vaccine candidates were identified and that phase 1 trial starts, already a group's writing the phase 2 protocol, already a group's writing the phase 3 protocol, starting to recruit patients, starting to get the infrastructure set up. That's a very expensive thing, and it's risky, because if it doesn't work in that phase 1, you just wasted a lot of time and money. And it's called an operation at risk. And you take that on and you say, I'm gonna gamble, and I'm gonna go ahead and get ready for this trial and spend a lot of time and resources and effort in case it works. And then when it did, boom, you go right to the next one. And when phase 2 works, you go boom, right to the next one. And so there was efficient, but no safety measures are cut at any point during that. So that's the other way. And then what differed as you know, part 2 of this that I've never seen happen and ever in a trial before, there's always a stated interest in diversity of the participants in a trial, right? The funders, whether it's the government or the company, they always say it would be great to have representation, you know, across racial and ethnic lines, and let's have a diverse population. And then it often doesn't really come true that way. You end up with 95% white participants. And this time it was stated again, as it often is. And then this time the sponsors, and both on the government side and then on the private side in the Pfizer study, followed it up with close monitoring of that, and then halting the trial. For one of the trials, they paused it early on and said, we don't have enough underrepresented minorities enrolled. Change what you're doing. How are you engaging? Who are you reaching out to? Stop just enrolling white people. And that had not happened before in a trial. And it was because of a lot of the things that Dr. Griffith was just talking about. We know that underrepresented minorities have been hit particularly hard by COVID. There's still a lot that is being explored about how much of that is any of it, any biological differences, or is much more of it have to do with those determinants of health. It seems more likely that latter category, but whatever it is, we know this is a high-risk group, and we need the participants in the trials to represent who's going to benefit potentially the most from this vaccine. And so that's what happened. And so the Moderna trial that we were involved in had about a 40% component of underrepresented minorities. That's far higher than any trial that I've been involved with before. And it was very intentional to get there. And I'll also say it wasn't easy because of some of the things we've alluded to with there's, I think, some distrust in the system, which unfortunately is earned. We know where it came from, and it's a barrier that we have to overcome. And that was a big part of this discussion. And I've never seen it in that way before.
Any follow-up comments or thoughts to Dr. Thompson's points?
Yeah, no, I appreciate his transparency and sort of really describing the process. I think that's really helpful because most people don't have answers to those very basic questions that he's been so able to really outline. And if you think about it, the other thing I'll say that's kind of, well, let me go back to my original thing, what I didn't really finish and do a good job of finishing was the determinants of health, and then get to sort of connecting that to what Dr. Thompson was saying. So when you think about racial and ethnic differences in particular, there's often been this tension of how much of it is, when you think about race, how much of the differences that you see in health are rooted in something biological, meaning that it's something inherent in the body that you can't change, versus something that is connected to the social factors and how they trigger things in the body. So it's kind of so without getting into the terminology, but basically, is it something that is getting turned into on and off by things that you're experiencing? Or is it something that is fundamentally just part of who you are that there's really nothing we can do about? We just have to manage and moderate sort of within that context. Racial disparities historically have been treated as though it's the latter, that it's things that are just in the body, that there's really nothing we can do about, and that it's just something fundamentally inherently wrong with the populations or bad about the population, but of no fault of their own. But it's just that something is fundamentally wrong that we can't do anything about. We just have to navigate around and try to figure out how we're going to cope with. And so when you think about, and so the determinants of health conversation and how that's really shaped this whole issue as it relates to COVID and a lot of the other factors is we've had to really think more critically about what does it mean to have this higher rate of engagement and participation of groups that are typically underrepresented. So underrepresented minorities, what he's talking about, are basically groups that typically are not included in the research to be able to answer basic questions, or even as professionals are typically not the ones who are conducting the trials or participating in conducting the trials. And so those are usually, to be very specific, are mostly African Americans and Latinx populations. Asian Americans tend not to be underrepresented in these kinds of trials necessarily, or that's not usually who we think of. Native Americans are another group that typically is underrepresented that we typically don't usually get, adequately representation of, but because of their size relative to other groups in the population, we haven't done as good a job as well in sort of bringing them in. When you think about underrepresented, it's really Latinx, Native American, and historically Black populations that are really we're talking about. And so part of the context of what I think I want to connect to what Dr. Thompson was sort of talking about is there was a political context to this development too that unfortunately really shaped how people were responding to different things. And just the fact that it unfortunately got politicized in a certain way, just in the context of, it wasn't just the pandemic happening, but then you also had, a presidential election that was happening, and there was a lot of things that were sort of being promised and suggested, and there were a lot of things that were just for those who knew about that history and that context, were exposed to and really, consuming a lot of that media. It raised questions that probably were not fair to the scientists and there wasn't as equal sort of space for the scientific community who were conducting the trials to respond to that and to say, no, here's the things that we're doing. They don't have the same platform to be as transparent about what's actually happening in the trial. What are the things that they're doing to make sure that these things are safe? What are the things that are being done to make sure that people are, here's what we're finding, here's what we're doing, here's how we're doing enrollment, here's how we're doing this, all of those kinds of things. The only things you would hear pop up is, oh, somebody got really ill in this trial, and so this had to be stopped, or somebody died in this. I don't think anybody died in any trials, but there was somebody, sorry, but there were a couple of severe illnesses where they did stop a couple of trials. And so those were the only things that got attention. The problem is, for the 99% of the people who had participated in the trial, there wasn't any attention to, hey, this is being fine. People are tolerating these things very well relative to those very small, literally handful of people that were getting severely ill. So part of the focus of that, what that triggers for people is often the historical context of things like, again, I mentioned sort of Tuskegee and this idea of trust and trustworthiness. So what that means is basically historically, we know that things have happened where our healthcare system, our public health system, both in terms of research and in clinical care, often are really somewhat interconnected. So if you think about these kinds of trials, the same people who are conducting the trials are the same people who are treating you if you get sick from the same kind of illness. You're being treated in the same place that they're actually recruiting and conducting the same research. Unfortunately, we've, as a scientific community, I'll just put it on that, have abused that trust. Let me just be really blunt about it in certain cases. And so Tuskegee often gets brought up because for multiple reasons, one of which it was all Black men. And there were specific reasons for that. Some of it had to do with the anatomy of looking at sexually transmitted infections. And they ended up dropping women. They originally had women and men in the trial. They dropped women out of the trial because frankly, you could see without keeping this relatively PG, it's easier to see a canker sore on male anatomy than it is on women's anatomy. So they ended up dropping women from that. But the motivation behind the trial was certainly problematic. But the most pernicious part of this that connects to what we're doing now and why that kind of keeps bubbling up is because part of what the deception was in the trial was that they were being told that they were giving treatment when they in fact were not. They were just in an observational trial, which means that they were just watching them to see what are the factors that contribute to how does syphilis basically affect the body over time. And the whole point of doing the trial was basically to see if there were racial differences. We already knew by the time they started the Tuskegee trial that we knew that there were racial, that we knew the natural course and history and what it did to the body of European populations. It was actually, I forget where the trial was actually done in the past, but they had done the autopsy studies and so forth. And so they wanted to see if there were biological differences in the Black body and how the Black body responded to syphilis in the same way. And so that was part of what underlied it. But the problem was, again, they lied to them and told them they were getting treatment when they were not. And they went out of their way to make sure that they couldn't get treatment once penicillin, which did treat syphilis and cured syphilis, was available because they thought they were more valuable to be participants in the study. So what the connection to now is, what we're seeing is people don't necessarily know a lot of those details that I just went through about Tuskegee. They do know that something happened where they just had Black men in the trial, and they weren't completely honest, they weren't completely transparent, and they actually actively deceived them. And then nothing happened to the people who actually conducted the trial. There were no consequences for any of the investigators who did it. There was no, the people got a settlement after it, but there was no, the positions there was no sort of censoring of them as researchers, as physicians. Nothing happened to anybody, and there were no consequences for that aside from the people who died in the trial. So when you think about it that way, there's a level of knowledge that we call mistrust, which is just, I know that there's a bunch of stuff that's happened, and that's just one of multiple trials that's actually happened. We know that these things have happened in the past, and that they've happened specifically to certain populations that are part of this underrepresented group that we were talking about before. And that when those things have happened, there haven't been consequences, or those things haven't been really remedied in a way that has actually helped people to feel like they should then trust the system again. But yet, when you have a drug like a new vaccine, you're expected to trust the same system that has historically done things that are problematic. And so the other layer to this is what we're calling distrust. And distrust is a little bit different from mistrust without the semantics. The semantics matter because if you think about who's going to distribute this vaccine, the COVID vaccine now and so forth, one of the things that we have to grapple with is it's going to be distributed primarily through the system that exists now. And if you have a history and a relationship with things like Vanderbilt Medical Center, and depending on their relationship with the community in Nashville, you have, a history of things like with Nashville General, you have, other hospital systems and so forth, or the public health system, like, the city and state health department and so forth that's going to be distributing the vaccine. It's distributed a lot through the relationship that we have through the existing infrastructure. I know some of the drug companies are potentially going to do things where they're trying to create a separate infrastructure, if I understand that correctly. But for the most part, it's really going to go through the existing structure. And the history of that relationship with the community is going to affect whether or not people are willing to take the vaccine, because it has to go through those existing structures and that existing history. And we know, for example, Vanderbilt has had a, complex history with the Black community here in Nashville, and so that history may influence, the distribution of certain things like the vaccine when it comes to the Nashville community.
Could I jump on and just quick comment on the end of that, because it's such a hugely important issue, and I thought that was a really nice sort of the history of this distrust. And as I mentioned, it's earned. We know why it is, and tragically it's earned, and it becomes a conversation that a lot of us have as we're trying to recruit for these trials. Is we know of these barriers, and it's difficult to know what to do to overcome them. When I sit down with the participant, they can't see into my heart, so to speak, and to know, that this is, these are honest people who care deeply for equity across racial and ethnic lines, of course, and that's a critical part of our mission, et cetera. But there's no way to convey that in a way. Trust has to be earned over time, and it's tough to know when we're in the middle of a pandemic and we're trying to rapidly recruit for studies. How does someone earn trust? And this idea of the sins of the fathers are visited upon the sons, right? I mean, my generation, everyone I've ever worked with on this, unfathomable. It's unfathomable what happened to Tuskegee and those sort of things, but it did happen, and we continue to pay the price of that. And so, I think awareness of it is crucial, and then it's transparency. It's as you said, it's everything is. The protocol is publicly available. The recruitment tactics are publicly available. The analysis, nothing should happen behind closed doors. And maybe that earns trust over time, but I think it's naive to think that it's going to be just a rapid fix.
That's a great point. And I want to just make a couple of statements, and then I want to bring on Alfonso Alexander for some additional questions. But just wanted to state to both Dr. Griffith and Dr. Thompson, thank you for highlighting the Tuskegee experiment phenomena. Believe it or not, this initiative, our first in-person session, unfortunately our only because of COVID-19, began with Dr. Wanamaker out of the University of Tennessee, who is one of the experts on the Tuskegee experiment and how it's actually impacted men's health, African Americans' men's health today. So I wanted to thank you for pointing that out. And I've got a couple other questions for you, but I think this dialogue is going really great. The audience is clamoring to get some questions from each of you. So I'm going to bring on Alfonso to keep the conversation going.
Sure. And guys, I have quite a few questions. So that means that your conversation has been very stimulating for the audience. These are coming in via Facebook as well as some via text from me. So I'll go ahead and shoot these questions out to you now. The first one is, what are the side effects of the vaccine, if any, and how severe are they?
Sure, I can take that one. Yeah, what we know, again, all of this is new, but what we know so far after several months and after nearly 100,000 people having received these vaccines in various trials, all of the side effects that we have seen are sort of immediate reactions to the vaccine as the immune system gets ramped up. So pain at the site of injection, fever, fatigue has been a big one. A lot of people very tired for 2 to 3 days after the vaccine. Sometimes we've heard some of our participants say the night or two after the vaccine, they woke up kind of with chills and just, you feel pretty rough. It's almost like a little bit of the flu, but it's short-lived. And then after that sort of second day, things pretty much go back to normal. We haven't seen in both of the large trials that we're hearing these results from now, no one's had to be hospitalized, no ongoing issues where they've had to start medicines or new diagnoses or anything like that. It's these short-term reactions. And it seems weird to say this, but if we're thinking about wanting the vaccine to be effective, some of those side effects are good to see, as we want the immune system to get a little angry at this germ, right? And so as long as it's within reason, it's controlled, and that's what it has been. You want to feel a little crummy after getting the vaccine because that's your immune response reacting, but then you want it to normalize. And so far, that's what we've seen.
Thank you for that, Dr. Thompson. That's very similar to what I understand from the traditional flu vaccines.
Yes.
As well. You have some of those same things, so that's encouraging. The next question, excuse me, is are there some people that should not take the vaccine, and if so, why?
Right now, we haven't seen any specific populations that, again, because it seemed so safe, there was no signal where you said, if you have X, Y, or Z, et cetera. Now, there were certain groups that have not been included in the trial, those with severe immune compromise. And so, people on chemotherapy or have issues with their immune system, they haven't yet been studied in this trial. So we don't yet know. And typically those types of people there are many vaccines that they don't get, and they rely on protection from others. If enough other people, it's this idea of herd protection or herd immunity. If we can get enough other people vaccinated, we don't have to risk it on somebody whose immune system is deficient and might have a different type of reaction. But right now, those 18 and above, without a severe immune system problem or something along those lines, would be eligible for it. We may have time later to talk about, as we prioritize different groups, because vaccine may be limited for a while. That becomes another really interesting and important topic. But yeah, right now, no groups would be flagged as should not receive it.
Okay, excellent. Thank you. What about if you've already had COVID-19? Do you need the vaccine, once you're eligible to take it?
Yeah, we don't know the answer to that yet. There's a huge amount of study still going into how much lasting immunity develops after infection. And we don't yet know. Probably what's going to happen is, again, as we talk about initially prioritizing people, we know that some of the people in the trial may actually have had COVID and, not known it or prior had it. And so we're going to have that information later. And so right now, someone, if they're more than about 3 or so months out of when they had COVID, they may be susceptible again, they may be vulnerable again, and they might be appropriate for the vaccine again, but that's not been finalized yet.
Excellent, thank you. Dr. Griffith?
Yeah, I just actually wanted to ask a question to Dr. Thompson, because I think you alluded to it, but we may not have caught it. So you said the vaccine trials are really for people 18 and older. And I know a lot of people have been concerned about children and their risk of, so what are the thoughts around how we should, be preparing, with, say, school age kids or high school kids and so forth? Where are we with that?
It's a hugely important area. It's a great question. There's been a big push from those of us in the pediatric infectious diseases field, especially, to say we've got to study this in kids. Those talks are ongoing. It's much, much more difficult to do. Recruitment is far more difficult in those populations. As you might imagine, a lot of us say, we're fine to sign ourselves up for something. If it's our child, it's a different analysis, and it's our tolerance of risk is a lot different, right? I might be willing to risk some side effects for me. If it's my kid, I have a much higher level of concern. Pfizer has just dropped their age of enrollment down to 12 for their study. And so they are just beginning to enroll 12 and above. That's as low as it is right now. Typically, the way this works is it gradually goes down, right? As we gain comfort and safety with a different age group, then the younger group can have some reassurance by that. Say, this was totally fine, 12 to 18, let's try 8 to 12 and kind of work down. But that's time consuming, and you're right, it's a hugely important area. We need to get going on it.
Excellent. You mentioned earlier, Dr. Thompson, that about 40% of the participants in the trials were minorities. Can you break those demographics down a little bit more, what that other 60% is and what the 40% is made up of in terms of different ethnic groups and gender?
I know it for the trial that we were involved with, the Moderna one, I know it better than for the Pfizer one, but for ours, again, nationally, this is 100 sites across the US, pooled that 30,000 participants, about 60% white, 40% non-white. Within that 40%, it was about half Latinx and about a quarter African-American, and then there was with the Asian American, and then I think the smallest group was Native Indigenous American. That's sort of the breakdown. And I think it's somewhat similar to the Pfizer group, about a third, 33 to 40%, something like that, of non-white enrollees.
Excellent. Thank you. This next question may be one better suited for the marketing and PR groups, but you guys may have some insight on it. The two questions, twofold. One is, how can we best offset the negative reporting about the clinical trials versus the overwhelming positive results? This gets back to some of the information that you shared, Dr. Thompson, earlier about the actual data, but then also Dr. Griffith that you referenced and shared when you told us that, really the good information isn't getting out there, just the negative components about some of the trials having to stop. So that's the first part of the question. And then the second part of the question is, how can we as individuals in the community help to encourage people to go to the right places to get the right information so that we can address some of the disparities in terms of the amount of information that's coming out?
Yeah, I can start. So, I think that the where to get the information, so there are going to be a couple of complicating things, and Dr. Thompson, I'm going to lean on you to basically help me with this part. So when the vaccine is finally available, part of the thing that we're going to have to deal with is it's not one vaccine, it's plural. So you actually have the Moderna vaccine, which operates slightly differently, if I understand this correctly, than say the Pfizer vaccine. And then you have several other companies that are developing different vaccines. So part of what's going to need to be communicated is not just how was the study done and so forth, but to more precisely what Dr. Thompson was talking about earlier, what are the side effects, and are there different side effects for different populations, or should there be some matching essentially of people and the vaccine that is developed by different companies? So that kind of information and correcting misinformation is going to be, I think, one of the first big things that's going to be really critical and important. And for the drug trials and for that information to basically try to get out there to try to balance out some of the misinformation and just the concerns that people legitimately have. But I think those are the kind of big things that I think for me are going to be really critical to the success of this.
And I think one of the challenges, I totally agree with that. And one of the challenges is we're learning as we're going. It's a moving target, and that becomes a challenge with all this. Is sometimes we don't yet have the answer, but we might later. And yeah, I think great resources for information. Someone's personal physician, and channels within the medical literature. Those are sort of carefully thought through information and data. The CDC is a good source of information. I think it's sometimes easier to say what's not a good source of information, which would be a random Twitter feed or somebody's Facebook page who's not in any way involved with any of this. And, I think we have to trust expertise at some level. I think, this is a challenge across any sector outside, whether it's medicine or whatever. I mean, it's, we have to have some degree of trust that the CDC and the FDA and the licensors of these vaccines, they've got everybody's best interest in heart. I know it's tough because the federal government has maybe not inspired a lot of faith for transparency and facts over the last few years. But, I think I know the people that are involved in this, and political pressures basically get ignored. It's just, what's the data? What does the science say? What's the right thing to do? What's safe here? And so I think we can rely on that.
So if I can just jump in with one, I know you have a lot of questions backed up, but I just want to sort of get to something really important here. So I think one of the questions of how to actually distribute or how to deal with misinformation is going to have to be for the professionals who actually have the content expertise to partner with or to figure out who are the key people in the community that are actually those thought leaders, who are the people that community actually trusts, and to get the right information to them. We know that from the work that I've done on particularly Black men and going to the doctor and so forth, if I don't have a relationship with my doctor, I'm not necessarily going to trust the information that he or she may give me or they may give me. I'm going to trust it. But if I know that person who wrote that blog post or wrote their Facebook thing that says blah, 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 they could have the least credibility or least sort of skill set to be or knowledge about that thing. But because they're in my network and because I know them and because I may trust and love them, I may trust that person more than the person who really knows the information. So one of the challenges that we have is we have to figure out how we're going to get information to the right people to correct that misinformation And the people that are going to correct the misinformation have to be trusted people who can counter that information with people in the community who have the right information. So that's going to be a critical part of this, how this is going to have to work if this is going to be successful.
Absolutely. Absolutely. So for all of you guys out there listening, if you are an influencer of other people, you've got to tell factual information and not just spread something that you saw that's not grounded in true research. And these guys have just shared with us some great places for us to be able to get that. If we're in organizations, let's get information out through our organizations as well. So thank you both for those comments. So next question, when we hear that there's 90 to 95% effectiveness of a vaccine, how does that compare to others that we trust, like the smallpox or chickenpox or flu vaccines?
Yeah, so it's most vaccines that we have licensed, that's part of the, most vaccines go into kids, the childhood immunization series. The majority of those are around 95% effective. This sort of matches that. One difference is the flu. Flu vaccines that we have to get every year, that varies a lot year by year. The flu virus changes pretty rapidly. It mutates sometimes even during the course of a given flu season. The average flu vaccine effectiveness is somewhere around 65 to 75%, somewhere in there. Some years it's in the 80s, a couple years it's been in the 40s. It really varies a lot based on the particular strain. We don't yet know how much the SARS-CoV-2 virus that causes COVID-19, we don't know how much that might change over time. We know it doesn't mutate nearly as fast as flu. But next year, year after that, is it still going to be 95% effective? We don't know that yet. It's all too new. We also don't know how long immunity will last from the vaccine. But so I'll say this, yeah, the 90 to 95% is excellent. It's about as good as any vaccine that we use. It is better than we were even hoping for, to be honest. And so I think it's very good news. Hopefully that will last, but we have to see.
Excellent, excellent.
If I can just reiterate one sort of quick thing that Dr. Thompson said, if we don't know how long the vaccine is going to last, so even we don't want misinformation to be, say I got the vaccine in December and then I contract COVID in July and you say, oh, the vaccine didn't work. No, it could just be that we don't know how long it actually lasts, how long the effectiveness is. And one of the challenges that we're going to face is basically, at least one of the vaccines, it's not a single dose, it's actually 2 doses, I believe. And so that's going to be the other part of this, is if you don't get both doses, I think it's the Pfizer vaccine, there's 2?
Both Moderna and Pfizer are 2 doses.
Okay,
yeah.
So that's going to be important. It's not just going to be a one-time thing that we're going to have to deal with.
Excellent, thank you. I'm going to kick it back over to Ken for each of the 3 of you guys to make some closing comments, and then I'll come back and close us out for the session. This has been phenomenal. Thank you guys so much. Ken?
Great. Thank you, Alfonso. And before I allow for closing comments, just wanted to ask one incoming question, and that really was related to the prioritization of the vaccine distribution based on occupation or other factors. Do we know? And then also, how does that look different in Tennessee versus other states as well?
Sure. So I think, while yes, as we've just said, extremely encouraging news about these 2 vaccines so far. As Dr. Griffith very correctly said, there are many others in development, and we are going to need more probably than just so taking the flu vaccine, for example, there are many flu vaccines on the market. Different ones are more optimal for different populations. And just from a production standpoint, one company can't make enough doses for the world to get 2 doses of their vaccine. We need as many as we can get, quite frankly. And so what we're about to see over the next month or so is so in mid-December, the FDA will meet to decide about the 2 vaccines that we've gotten the most data so far, Pfizer and Moderna, decide if they're going to give emergency use authorization for those 2, at which point we can start vaccinating, but there are not going to be very many doses to go around. So there's going to be prioritization of who can receive that. Those conversations are still ongoing, but there's essentially uniform agreement that we need to target those who will benefit the most, right? So the high risk populations and those most critical and crucial for our pandemic response and to keep society going, quite frankly. So frontline healthcare providers are sort of the tier 1A, so emergency nurses and physicians and ambulance drivers and ICU physicians, things like that, right at the top. Then after that, it's higher risk populations, older adults. This is where some of the racial and ethnic disparities come into play. It may be worthwhile to target minority populations who have been shown to have more severe outcomes and have worse outcomes. And we need to target those who have showed the most benefit from the vaccine. And so there'll be prioritization that will be determined, and those conversations are happening. And then as hopefully more, if we get additional vaccines from other manufacturers come online, we can get more widespread protection soon. We still have another trial going on at Vanderbilt right now, a company called Janssen that's affiliated with Johnson & Johnson. They have a single dose vaccine. This would be, we're studying is 1 dose as good as 2 doses. I'll put that information in the chat if anyone wants to participate in that. That's ongoing. And so again, hopefully we'll have more than just 2 down the road so that we can get widespread access to everybody.
A couple of questions, and then Alfonso, if you're okay, I'm going to come back to you for any other pressing questions from the audience, and then we can go on to closing comments. But really, a question for both you, Dr. Griffith, and you, Dr. Thompson. What does success look like from your perspective 6 months from now as it relates to the activities currently going on for the vaccine effort for COVID-19?
So I think success, it's an interesting and difficult question, because I think part of what we have to also realize is even if we have a vaccine, even if we get the emergency approval in December, we're still going to have to do a lot of the things that we've been inconvenienced with doing over the last year, that those things are going to have to continue. And for the foreseeable future, even with the vaccine and as it's rolling out, we're still going to have to do all those things. We're still going to have to keep the social distancing for now. We're still going to have to wear masks. We're still going to have to do all these things until we sort of reach a point where these things are, where we have kind of what Dr. Thompson was talking about, the herd immunity, or enough of the population where the likelihood of you contracting it is really minimal. So part of the challenge that we're going to face as we go forward is, how are we going to combat the misinformation that's out there and just the fatigue of constantly having to do these things that we're frankly grown very tired of, and rightly so, but it's exhausting but necessary for us to take these kind of additional precautions. I think success for me looks like, we're able to sort of battle through the fatigue and, continue to do the things that are helping us from a public health standpoint, the wearing the mask, social distancing, doing those kinds of things. But then also you're starting to see the uptake in the vaccine and people having good success with it. And you're actually starting to see the stories of that information getting out so that people are actually feeling comfortable with what's happening. And that the other thing that I would hope happens is that we don't have a lot of negative outcomes from people that didn't get attributed to the vaccine, so that there aren't, we don't know long-term effects because we haven't had a chance to study these. So we don't want to see if there are any other those things that happen, but I would hope that none of those things happen.
Yeah, I just want to echo one small part of that to say the vaccine news that we've gotten and the others in development, it is a light at the end of the tunnel. This is our clearest path. I don't like to say back to before the pandemic, because some things have changed forever, but at least our path forward out of this is the light at the end of the tunnel. But we can't give up now on these distancing measures and wearing masks and safety. Let's not drive the car into the wall right when we see the light at the end of the tunnel. I think this should be wind in our sails to say we can get through this. But I'm worried it's going to get worse before it gets better. The numbers are bad right now. Vanderbilt Hospital is full. Most surrounding hospitals are full. It's bad. I'm worried it's going to get worse before it gets better. We're not seeing my family for Thanksgiving. The family I live with, I am, but not my extended family. Those sort of things. We've got to be careful. We've got a light at the end of the tunnel, but it's going to be a couple more months before we have access to that at least, and we've got to be careful in the meantime.
I'm going to hand it back over to Alfonso. I think there's some other questions, and we got pretty good engagement from the Facebook group, so didn't want to miss out any pressing questions that we can get on record. So, Alfonso.
Sure. The first one, I think, may be a quick one, is affordability for the vaccine. Can you speak to that?
So my hope is, as we saw with COVID testing, most major insurance companies, Government-funded insurance programs essentially made it either free or very inexpensive to get COVID tested because we recognize it as a critical part of pandemic response. I'm very hopeful that the same will be recognized for the vaccine, and I think it will be, at least on a federal level. It's identified. We can't have cost be a barrier to this. So I can't sit here and say it's going to be free for everyone. I hope that's true. I think it has been recognized by all levels of federal leadership that cost cannot be a barrier for this.
Excellent. The only potential quick wrinkle to that is some of the companies took federal money to help develop the vaccine, and the federal government may have more control over their costs. So some of the companies did not, and so there may not be as much control over their costs. So there may be some discrepancies in that as an access factor too.
Okay, wonderful. And then the fact that the vaccines have to be held at such a very, very low temperature, I'm sure that's additional cost for hospitals. Is there any impact there in terms of the cost that would be pushed back down to the customer, or is it too early to tell?
It shouldn't be an issue from cost getting pushed down to the customer. It may be an issue with availability and distribution. It is a challenge, and there are some areas that just simply don't have the extreme cold storage to be able to, especially as we think about this as a global response and not just in the US. And there are certainly many areas of the world that just simply don't have a way to maintain that cold chain to the degree that's necessary. Two things to say real quick on that. Number one, I mentioned some of these other trials that are ongoing. Many of those involve vaccines that may not need to that level of cold storage, and so some of them may be more widespread. For us locally, Tennessee is a trial site that Pfizer is using as sort of having cold storage shipped as part of that, and sort of covering that aspect of the distribution plan. And so we're a little bit just lucky for where we are, that I'm hopeful that in our area compared to some others, it won't be as much of a barrier, but that will probably limit. It gets back to having to prioritize certain populations, because it's just not going to be something where every Kroger and Walgreens in a month is going to have a vaccine. It's not going to be anywhere close to that, unfortunately.
Sure. Thank you for that. I know you referenced earlier, both of you guys did, us getting our information from social media. There's a question that came up about a video that's been circulating saying, don't take the vaccine because it's a way to embed some tracking mechanism in you, and that would be dangerous. I know I walk around with a tracking mechanism all day here, but could you guys address that question?
Yeah, I mean, what I can say definitively is, I think first of all, we just simply know that there's nothing like that is the case. I'm not even sure that type of technology exists that you could sort of widespread involve that. But even if it did, that's just in no way part of this. I've been very troubled by a lot of conspiracy type things that I've seen, and I don't fully understand where they come from. I don't understand the source. You know, this is our way to get the world back, and sort of fabricating things that would seed confusion and fear and distrust. It's very troubling to those of us that have, not seen our family much for the last 6 months, as we've been trying to get these things available to everyone that can benefit from them. I think please, I think one thing you'll see as soon as this vaccine hits the market, you'll see I mentioned those frontline healthcare providers being that sort of very top tier, ER, nurses, physicians, they're going to be lined up to get this vaccine. And so if everybody else has a little bit of distrust, say, I don't know, I'd like somebody else to go first. A lot of people are happy to go first. A lot of people are getting in line to get this vaccine. So take solace there. Let them see that they're not getting injected with tracking devices. They're getting a vaccine that's going to try to get COVID not circulating. And maybe there's additional trust at that point.
Yeah, Dr. Thompson and Dr. Griffith, I want to just acknowledge what you just said there, Dr. Thompson. I truly, truly respect the work that you guys are doing and how you are sacrificing by putting in the hours that you're putting in, not being able to spend time with your family, and all of the things that it takes to try to save the rest of us, and the research that you both are doing to help us provide us information so that we can understand what we're dealing with here. So I tremendously respect what you guys are doing, and thank you for that. And I'm sure the rest of our listeners agree. This is phenomenal work that you've shared, phenomenal information. There are great comments in the Facebook feed, just thanking you guys for how much of a blessing this is that you're sharing this information with us. You have answered the majority of the questions that have come through. Some of them have been very similar to other questions that I've asked. So I'm going to stop here. I did post in the Facebook feed the question email that you shared with us, Dr. Thompson, so that if anybody has additional questions that we did not get to ask, you can go into the feed and see them there. I see thank yous coming in again for your service for both of you guys. And again, we just really appreciate what you're doing, but also the fact that you took away time from that work, from your families, to share this information with us today. Because as you guys both said, we need to get to the community of influencers to be able to spread the correct messages so that we can all get healed as quickly as we can from this global situation that we're dealing with. So thank you again so much. If there are any other questions or any other closing comments, any questions that you guys would like to react to, or any closing comments that you guys would like to make, I'll give you that opportunity now before we close out.
I mean, I can start. I mean, first of all, thank you all for giving us this platform, for creating this platform, this opportunity for this information to get out there. I think, we definitely constantly need more of these opportunities for folks who, particularly for the Dr. Thompsons, who are actually more involved on the ground with the development of these kinds of things, to be able to speak directly to people, for them to put a name to a face, and to be able to actually see who are the people behind this stuff that we're hearing all this stuff about. I think one of the things we know about health is that often, health is not our top priority. I mean, and as counterintuitive as it is to say that, we know that we sacrifice a lot to, most of the people, if you think about the reasons that you're actually still going out, is usually it has to do with work. It has to do with sort of providing for basic needs and so forth. And we tend to prioritize those more than our health. And if you think about the ways that the politics and all those kinds of things, and even the politics of, wearing masks and so forth, and, the social distancing, a lot of that has to do with money, whether at an individual level or at a community level or what have you. And so we have to think about that and just recognize the tensions that were inherent in how we're just trying to survive at a very basic level, that some of these things, whether it's the vaccine or whether it's some of the other behaviors that we're trying to engage in, you have to recognize the challenge that it's not a zero-sum game. You're still going to have to try to be as healthy as you can, but try to do those things that are going to allow you to still function in life, but try not to sort of pit the health against money or against your ability to sort of keep a livelihood. We know that you have to do both, but it's going to be important to strike as good a balance as you can to do both of those things in our lives.
Excellent. Thank you.
That's extremely well said. I concur with that. I might just add as a final thing, just to everybody that's listening or sees this, I mentioned that we hopefully have a light at the end of the tunnel, but it's going to get bad. And if there's any remaining question about the COVID being serious, being real, I want to assure, because there's still, I still hear doubt and, I think this has been overblown. Do we really need to take these measures? Is it really that bad? I think there's something as a species, as a human species, we have a poor ability to take something serious until it hits us in the face. I think it starts with I see this with my kids. I see them doing something dangerous. So you're going to hurt yourself. You're going to hurt yourself. And they keep doing it. And then they hurt themselves. And then they say, why didn't somebody tell me? I said, oh my gosh. But it's not just kids. It goes across, people say, I didn't, and I hear from my friends over in the ICU right now, people that are about to go on ventilators and they may not survive COVID. And the last things they're saying before they go on a ventilator is, I really didn't think this was going to be that big of a deal. They hear it every day. I just didn't think this was that serious. I wasn't trying that hard to distance all these things. And we can't let it hit us in the face, because it's happened. 250,000 of Americans have died. And the numbers rising fast. So we've got to take this seriously. There is hope. It's incredible hope. It's quite frankly better than I thought it would be, from promise of the vaccines, how quickly we've gotten them there, how safe they appear. 2 months ago, I thought this is gonna. I don't know what the next year is gonna look like, and now I think there is hope here. We've got to get through this for a couple more months. We've got to be careful. We've got to distance, mask, avoid large gatherings. Let this Thanksgiving be small so no one's missing next year. The holidays, let them be small this time so everybody is there to celebrate next year. I think that's the message I want to get out.
Outstanding. Thank you so very much. Again, thank you guys for being here today and joining in this phenomenal discussion. I want to thank Dr. Lovett for moderating a great discussion with Dr. Griffith and Dr. Thompson. Remember, Man Up, Men's Health Initiatives. We come to you just about every month with some new topic that's relevant to health for men and particularly for African-American men. I thank these three gentlemen for all that they do and sharing this information in this time. And I thank you for joining us as well. Have a great day. Have a safe Thanksgiving and stay home and be safe. Take care.